So welcome back, everyone. We are honored to have Dr. Ganapathy with us. He is one of the world's most renowned neurosurgeons. He is an experienced and celebrated professor. He's taught medicine and medical management all over the world. He's taught at Columbia with me many times. He's been president of the telehealth organization. He's been a longtime executive in Apollo Hospitals, which is, I think, the fourth largest healthcare organization in the world. He's headed their philanthropic efforts. He has been an innovator in medicine across the board and in management. He's an entrepreneur. And I really, truly believe that when history writes the history of the 21st century, he will be one of the most noted people of the 21st century. His work in telehealth is groundbreaking, and it continues to this day. And on top of his many skills and knowledge and medical expertise, he's just a genuinely good person who makes the world a better place every day that he wakes up. So I'm very grateful to him for all the things he has done for me and for us. And it's just a great honor to introduce him. So, Doctor, if you'll take over, please.
Thank you, Professor Aimike. I wish I could believe 10% of what you said. You're able to see my slide now?
Yes.
Okay, fine. I'm going to divide my talk into two portions. The first portion is going to tell you, it's not a sales pitch really, but it's just to give you the background so that you understand what exactly we are actually doing in the real world. The second half of the talk is going to talk about how we are able to do it. There's a disclaimer. I do not have a degree in business management. Most of us who run the largest telehealth organization in South Asia, most of us are just street smart. We have learned it the hard way. I believe you cannot learn swimming by a postal course. You have to get into the water. You have to dirty your hands. You have to roll up your sleeves. And this is the information which I'm sharing with you, acquired painstakingly over the last quarter of a century. Now, since this is a heterogeneous audience, forgive me if all this is very familiar to you, but today we talk about technology-enabled remote healthcare. When I started telemedicine in 1998, the world was totally different. Today, we need to attend to not just hardware, software, connectivity, acquisition, storage, retrieval, and display. We also need to be future ready. And India, like most of the advanced countries, is slowly becoming regulatory minded. We need to comply with regulations. We need to customize. India is a planet by itself. It's not a country. It's not even a continent. And therefore, we need to be one size doesn't fit all. We need to customize everything. So it is this background that I'm talking. Dr. Pratap Reddy, who was instrumental in making available private healthcare to this country, at the height of the pandemic, he said, we need to double our doctors, triple our nurses, quadruple our paramedics to meet the health staff requirement in the country. And he remarked, treatment outside hospitals is going to be the future of healthcare. I strongly believe a doctor in your pocket, a laboratory in your pocket, even a hospital in your pocket is going to happen in my lifetime. The numbers are perhaps not very important, but what is important is the fact that every one of this is being continuously done today. Today, we have an entire division which I head called the Remote Healthcare Division. We have about 375 full-time employees in this division and almost 1,000 people in addition working on several projects. The largest public-private partnership with government To the best of my knowledge, we have published this also. We have 750 public health centers and more than 17 million teleconsultations have been delivered over the last 15 years across 25 different specialties. Teleradiology, I'm only talking of government, public PPP. We do about 1,200 reports per day. We have the largest EICU. We have more than 27 intensive care units across 7 states in India connected to a command center at the Apollo Hospitals, Hyderabad. This is what we started about 6 years ago. At any given time, this has a capacity of 260 people can be here. At any given time, we have at least 160 people answering questions which are escalated from a telephonic consultation to a video consultation to, if necessary, a specialist and even a super specialist consultation. This service is available 24/11. During the last few years particularly, I am convinced that this is going to be the hospital of the future. Why the future? This is probably going to be the hospital in the next few years and certainly in India. The Ayushman Bharat, the world's largest public program, which caters to 500 million of the 1,400 million Indians who are in the lower income group, they have already starting 150,000 telehealth centers with wellness programs, which will have smaller versions of this. Now, I like this word tectonic. I have actually borrowed the slide from my boss, Sangeeta Reddy, the Joint Managing Director of the Apollo Group. I think this is what Apollo is really doing. We cause a major upheaval. We cause an earthquake, so to say, in a country which was derogatively known even 10, 15 years ago as a third world country. From the 5th largest economy in the world, we are on our way to becoming the 3rd largest economy in the next decade or so. Whether it be robotic surgical systems, we have 18 of them, a single group of hospitals. We have 18 institutes of robotic surgery spread over the country, whether it is advanced diagnostics in the form of PET, MRI, genomic testing. Never would I have thought that in my lifetime, I could take out 2 ml of blood in a tier 2 city, have it sent to an advanced center and do 98% of the genetic tests which are now available at NIH Bethesda, Maryland, for about 7% of the cost in the United States. We have a proton therapy for cancer, one of less than 50 units worldwide. We had a 640 slice CT. We were the 3rd in the world after Johns Hopkins and Cleveland Clinic, and so on and so forth. Predictive diagnostics and healthcare using artificial intelligence. We also have created the largest, what we call omni-channel healthcare platform. We believe that healthcare is much more than a single patient-doctor interaction, which is how I started my health career a half a century ago. Today, a healthcare provider, I use the word healthcare provider deliberately, not the word doctor, because in several instances, a medical doctor, an MD, may not really be required. We have a super app, as we call it, which addresses all the healthcare needs of a consumer, be it pharmacy, be it insurance, be it wellness, be it yoga, a virtual doctor consultation, online diagnostic booking, and so on and so forth. AI is not a buzzword which we use as a marketing strategy. Today, we are very happy to inform you that Apollo Hospitals is doing major projects with Google, Microsoft, Azure, National University of Singapore, and I think there are 2 universities in the US, the Imperial College in London, and so on. We have patented, we have used our own software algorithms based entirely on indigenous data. So you can see here, the AI augmented pathways include imaging. We use AI to read X-rays, mammograms, ECGs, and so on and so forth. Clinically, in the real world, we have what is called Apollo years, which is an antibiotic resistance project. You know that antimicrobial resistance is a major product worldwide. And today we have customized and developed an AI platform to avoid the use of inappropriate or unnecessary antibiotics. Similarly, COPD, chronic obstructive pulmonary disease, we have this for diabetes, pre-diabetes. India is unfortunately becoming the diabetic capital of the world, and we are going all out to use AI to diagnose pre-diabetes. Prospective, well-designed research studies are being carried out in conjunction with a few other countries as well. Our partner hospitals, as you can see in the bottom of the slide, are from Singapore, Dubai, Canada, ongoing discussions with the NHS, the United Kingdom, and so on and so forth. We also have what I call the digital dispensary. This is a pilot project started about 2 years ago, where we locate digital dispensaries in places where healthcare access is more than 8 to 10 kilometers, 5 miles. Teleconsultations with at least 15 specialty and super specialty doctors are enabled by our telehealth coordinators, most of whom are actually school dropouts. We have trained them, and since the software is intuitive and so user-friendly, even a school dropout is able to manage this. Incidentally, we provide them, these are all people recruited from the local community, and in a small way, we are able to provide occupation to these people. This was showcased at the World Economic Forum's annual meeting a few months ago as an example of a digital health innovation in the country. I started tele-emergency medical services 6 years ago in the Himalayas at a height of 14,500 feet. We have published 3 papers which have been cited extensively, and also a chapter in a textbook. Today, we have 10 tele-emergency centers spread throughout India. Where in the world can you get a cardiologist to appear on a screen within 20 minutes, 24/7? We have treated, diagnosed, identified hundreds of people with developing stroke, with developing cardiac thrombosis and so on, and initiated antithrombolytic therapy. Today, we are listed among the best and replicable practices by the Ministry of Health, and this is available in the public domain. A hospital on wheels. We believe not in the lifetime of my great-great-grandchildren will there be enough doctors, paramedics, nurses in brick and mortar hospitals in India, as it is true in most other countries in the world. We believe that mobile medical units or a hospital on wheels is another solution, and we have 15 of these at the moment going about to various places every day of the week, most of them the towns, and they include a mobile OPD. We do NCD screening, non-communicable diseases. We have POCD, point of care diagnostics, anemia tracking, counseling, and so on and so forth. We were very happy that recently the World Economic Forum and the government of Meghalaya, which is a very, very small state in northeastern India, chose us for a very major pilot project on screening for cancer. Meghalaya, for some strange reason, has certain types of cancer as an epidemic, and today we are using technology to screen more than 200,000 people in remote tribal areas. We hope to do genomic studies as well, and hopefully in 2 to 3 years, we will be able to bring out a paper which will show how cancer screening can be done cost effectively anywhere in the world. We always believe that we must be ahead of the curve. 5G, the government of India has taken 5G as a major challenge. It is amazing that the gap between 5G in India and the most advanced countries with 5G like Korea, Singapore, Japan, etc. is steadily narrowing. In fact, the government has already set up a committee to study 6G, and it is hoped that in 2 years from now, we will talk about the relevance of 6G in India. So we already have connected ambulances, pre-hospital management, we talk of video calling, notification center, and so on and so forth. all our devices in a hospital in the pre-hospital management is 5G enabled, and studies are going on. I belong to the BC era. I unfortunately asked the question, so what? To all my colleagues, including my bosses. Many of them are unhappy with it. I believe that technology is a means to achieve an end and not an end by itself. A fool with a tool is still a fool. When you have a hammer, everything around you looks like a nail. And if it is an expensive hammer, more so. So right now, I'm trying my best to see if we could do a prospective study in which we scientifically, with statistical significance, try to prove that the involvement or use of 5G definitely makes a difference in the healthcare outcome of my individual patient. I am not overawed by the multinational companies, the hype which 5G has. Honestly, 5G is used as a marketing tool, but I would like to have evidence that 5G really made a difference, and hopefully one of these studies will carry on. For the last 2 years, actually 4 years ago, I started the concept of drones. We were too far ahead of the time. Regulations was a deterrent to us. But now the government of India has woken up, and it's amazing how regulations are now not as stringent as it was before. And again, with the World Economic Forum, a newsletter, a publication was brought out a few months ago. The pilot project is over. I believe we used to suffer from a disease called pilotitis. Everything pilot, proof of concept, validation, and so on. That is over. We have learned how we are fine-tuned, and I think we are ready now to employ drones in healthcare in a realistic way, particularly in areas where terrains are very difficult and surface transport is extremely difficult. How many of you know that we run 110 ophthalmology centers in a PPP with the erstwhile government of Andhra Pradesh, where almost 10 to 12 people come every single day in each of the 110 units. We have already covered, as I'll show you in a minute, several million fundus examinations done remotely. And I'll come to that in a minute. This is again the ICU, which more than 100 clinical protocols have been inbuilt. 200 ICU beds are managed remotely. And this is also a very strong point which we have. Here is an ICU nurse at the command center at Hyderabad. This is what I was referring to. This was yesterday. All this is available on the dashboard. Theoretically, yesterday evening at 6 o'clock, if I had bothered to log in, I would have got the statistics of yesterday evening. I'm a little lazy, so I got it on the 4th of July. As on the 4th of July, we had examined 2.68 million patients multiplied by 2, 5.6 million fundus examinations have been done, and this is being done as an ongoing process. These are all real-time dashboards, total transparency, authorized people, third-party audit is done by the government, and most state governments are now unbelievable. Even the compensation which we get is based on our performance, and unless we achieve an efficiency of 98.5%, the monthly or the bi-monthly financial releases are not even made. So everything is third-party audit. You can see 100 out of the 100 centers are active. This is something remarkable in a public-private partnership. Equipment, we also do detailed monitoring of all the equipment we have. We are obsessed with quality control, and we do remote quality control from Hyderabad. Again, a paper has been published on this. During the COVID, Apollo hospitals proved that it is not a quaternary care center which specializes in pediatric liver, lung transplant, pancreas transplant, surgery of the unborn, and so on and so forth. For the first time, we went into primary healthcare, and again, for a corporate hospital group, a dividend declaring company, one listed on the stock exchange. I think this was remarkable. They have submitted a paper to show the diversified use of technology in COVID-19 management. The numbers speak for itself. 239 videos and snippets resulted in 100 million views. And again, online COVID risk assessment scan, which was made freely available to the public, was used by 18 million people from 53 countries, and so on and so forth. We published a war kit called the Red Book, which was updated 25 times, electronically shared with 20,000 small nursing homes. COVID tele-ICU centers were set up in just 10 days. Can you imagine? Every one of the photographs shown here was set up in 240 hours. And where were they set up? They were set up in remote, disturbed areas, in thermal power stations of the government of India, located in remote areas for the National Thermal Power Corporation, a government of India undertaking which supplies almost 10% of India's power. So this is what we managed to do in the Indo-China border, in the Indo-Pakistan border, and so on. Simultaneously, we run the largest simulation laboratory in this part of the world, built at a cost of several $1 million. Today, we have anatomical simulation models, and our simulation center is recognized by the National Medical Commission, and we have postgraduates from many medical schools coming over here to spend some time. No man is an island into himself. Apollo hospitals cannot exist in isolation. We believe in partnerships with leaders in technology, healthcare, and academia. We have major ongoing projects with Azure, Microsoft, with the MIT, the Massachusetts Information and Technology, with Google, Intel, and Massachusetts Imperial College London, and so on and so forth. So, ladies and gentlemen, I have given you a background. How are we sustaining this? The first thing which I learned 25 years ago is that making profit is not a dirty word. Unfortunately, whether you like it or not, philanthropy at the best can only start a project. I derisively call them photo op opportunities. In many instances, we have had donations, CSR activities, and so on. We start a project, take a photograph, cut the ribbon, the local member of parliament, member of the legislative assembly, etc. I call them photo op opportunities. A large percentage ended in obituaries. How is it we are still sustaining? We are one of the very few telehealth projects in the world which not only are sustaining, but which are slowly growing. It is not a radical transformation, but there is certainly an incremental annual growth. And this we are doing purely because of the tremendous, it is now become a part of our DNA. I don't even analyze it. It is only for writing papers and for giving talks like this that I sat down, tried to analyze, consulted my colleagues, etc., and put up this. It just goes on. It's an autopilot. Today, I honestly do not know. I've been kicked upstairs, so I have no idea what really it does. The CEO also delegates authority. I think one of the reasons why we are fairly successful is we follow in the footsteps of our boss, Dr. Pratap Reddy. The secret of the success of Apollo hospitals to me is that the big boss identified the right person at the right time, at the right place, and gave him total carte blanche. When I have so much responsibility thrust on me, I go out of my way. I do better than my best to ensure that my boss's trust in me is not misplaced. Micromanagement is something which I used to do, particularly as a neurosurgeon. I was obsessed to ensure that the blood group of the patient was correct. I was obsessed to know each and everything. Today, in the modern world, I realized that trust and faith is very essential. And I do not know about management. I have no idea what they teach you, either at Columbia Management or at Harvard or Wharton or all the big institutions. But we believe in trust and health. A detailed need assessment study. This is the first thing we do. In the earlier years, I used to go myself. Now, because of my white silver hair, I am not going. And again, the next generation has very successfully taken over. A detailed need assessment study is done. I cater to the people, to the beneficiaries. We understand very clearly that the beneficiaries in Meghalaya are totally different from the urban elite in Madras. we convinced or tried to convince the remote doctors to become champions. We recruit people from the locales, as I call them. All our projects, it is the local people who are the champions, not an American board certified doctor who is sent to a remote area. Our program managers from day one, from minus day one, are taught to be transparent, accountable, and responsible. Implementation components, we are obsessed with training, weekly, monthly, project reporting, CME programs for doctors, nurses, paramedics, capacity building, and finally, an external independent third-party audit. Sustainability depends on modifying existing infrastructure, the processes in the local healthcare delivery system. We do not solve a problem, which is difficult to solve a problem. We work around the problem. Problems will continue. It is impossible not to have a problem. So what do? We do the second best. We try to work around the problem. Policy frameworks, communication technology costs, and finally, acceptance. Behavioral modification. These are a terminology used in the published literature. We use simple words. We say physician-patient acceptance. At the end of the day, my brand ambassador is not the chapters I write, not the lectures I give, but a patient, the end user. He goes by word of mouth. He says, look, I saw a doctor on a screen. I saw a doctor on my mobile phone. He spoke to me in a language which I understand. He spoke to me in Himachali, not even in Hindi. He spoke to me in the same dialect, with the same voice. He understands. He got into my brain. He knows exactly what I want. And this is what we aim at. It is not customer satisfaction. We keep raising the bar. We believe in customer delight. I don't think Twitter, Instagram, Facebook, and all the social media has been responsible for our increase in the use of social health. It is purely a satisfied, a delighted customer. And when the customer is delighted, believe me, a doctor is even more than delighted. Unlike other businessmen, doctors still retain some of the reasons why they became a doctor. We became doctors 20, 30, 40, 50 years ago because we honestly believe that wiping the tears off a patient gives us enormous support. And today, ladies and gentlemen, it's possible to do that virtually. I do not have to be physically with somebody to hold a hand. All I need is to empathize, sympathize, understand what the patient was, and use technology to get into his brain to satisfy what he wants. So this is what is our primary goal. Program implementation, technology acceptance. Of course, our technology must be superb. We have a backup 1, we have a backup 2, we have a backup 3. Now, I believe I do not want CNN quality. I do not want BBC quality. I would rather have 1 Mbps, 100% dependable than say I have 500 Mbps. Today, I'm talking from the comfort of my home. I have 320 Mbps download, upload speed. I don't necessarily have this in the remote areas of India. So we ensure that the audio signals, the video signals very rarely go, there's a drop. Yes, we do have occasional drops, but never have we closed down a unit for more than 2 or 3 hours. A detailed SOP. We believe that everything should be reduced to algorithms, flow charts, standard operating procedures. Language is very, very important. Many of us do not speak the local language. We have English-speaking translators at the remote end who communicate with American board-certified doctors. We have dedicated generators. I go into all these minute details. Diesel. Do we have enough diesel to ensure that the backup generator is on? We have solar panels. A remote drug list. There is no point in a city doctor prescribing drugs which were made available yesterday in New York. So we ensure that the drug list which is available in the remote areas are made available to the urban specialists. The rate of adoption is the speed with which a technology is adopted. Evaluation and monitoring is mandatory. As I mentioned earlier, we have a continuous quality improvement program. Enforcing standards, accreditation is crucial in maintaining this. We are taught, and this is what I teach. I do not compare myself with other telehealth organizations in the regional parts of India. The benchmark we always use, Apollo Hospitals uses as a benchmark. All its departments are Johns Hopkins, Mayo Clinic, and Cleveland. Mayo Clinic and Cleveland. The CEOs of all these three organizations have physically visited the Apollo hospitals and seen for themselves how we are able to maintain almost the same landmark, and in some of them actually do better than them at 20% of the cost. Skillful planning, implementation as essential as system design, software functionality, and technical prowess, all these are important. Optimization of work processes, identifying pain points. We spend much more time in when we fail than we succeed. We have detailed discussions as to why this went wrong, why that went wrong, to ensure that this is not repeated in the future. We measure. We believe what the management guru says, that if something cannot be measured and quantified, whether it be happiness, whether it be satisfaction, whether it be HbA1c values, whether it be urea creatinine values, we measure. That is our mantra. We select measurable characteristics, choose a method to measure. And again, I very strongly believe that a solution is not a solution unless it is universally available to everyone, anytime, anywhere. There is no point in copying a questionnaire used in Chicago or Houston and try to use it in the remote parts of India. Yes, we use the questionnaires used in the UK, in Europe, and the US as a basis, but then we change it depending on our needs. How do I judge the success of a telemedicine unit? We have hundreds of telemedicine units today. What do my officers do? They have different criteria. The performance criteria differs for a manager, differs for a telehealth coordinator, differs for a teleconsultant, for the finance officer, and so on and so forth. Measuring impact should be contextual. I think this is one thing which many people don't pay attention to. It should be contextual. I very, very strongly believe that nothing is written in stone. Everything has to be modified. Everything is to be dynamic. It may have to be modified once in a few days, once in a few months. It may even have to be modified within a single day. Indicators indicate impact, whereas metrics are numerical indicators allowing quantification. What are the things we measure? Utilization. How busy is the network? If 5 people come to a telemedicine center from 9 a.m. to 5 p.m. and in another center 50 people come, do I say the center with 5 people is a failure? No, not at all. Because the center with 5 people has a population of 34,000 distributed over 300 kilometers. The population density of the center where 2 people come per day is 10 per kilometer. You need to understand, it's very easy to provide healthcare to New York, to Chicago, to Madras, to Bombay, to Delhi, where the population is 13 million to 15 million. It's extremely difficult to provide healthcare to a population of 35,000 people spread over 500 kilometers. This is also what we do. To that 2 people who are making use of it every day, we are a savior, and the satisfaction level there is very high. Therefore, ladies and gentlemen, unlike the CFO, I do not judge the success of a unit purely by quantity, purely by number. I also factor in my favorite question, so what? What did I do for that individual patient? One patient comes a week, I will still not close down the telemedicine unit. For that one person, it is 100% success. We have a lot of barriers to adoption of telemedicine. It's not simple child's play. These include economic factors, hurdles like reimbursement. This was a major problem we had 5-10 years ago. Today, I understand that India is the largest in the world so far as UPI transactions are concerned. I'm told it's almost 2 billion. Yes, it's not a mistake. I'm talking of BI, not MI. We have 2,000 million digital financial transactions occurring every single day through GPay, PhonePe, and many such schemes. And these are in the range of 10 cents, 20 cents, 50 cents. It is what is transferred into billions per day. So today with digital transaction, reimbursement is not at all a problem. I published a paper a couple of years ago, and this is now used by the government also, that we showed the economic viability of a technology-enabled remote healthcare. This is all public-private partnership. We proved that laboratory tests cost 29% of that in private laboratories, that we had 3 times more tests available in a PPP primary health center than in a private laboratory in a tier 2 town or in a small town. The figures speak for themselves. The cost per specialist teleconsultation factor in every single entity at a remote center, I'm talking of super specialist also, was $2.2. Where in the world would a pediatric neurosurgeon give a consultation within 12 hours in the remotest part of the world for a total cost of $2? This is what public-private partnership achieves. Management concerns, again, I've already mentioned this, identifying champions, perspectives, measure, reproduce, and so on and so forth. Acceptance by clinicians and beneficiaries. Secondary, okay, what are the secondary benefits? The secondary benefits we have noted are because of the virtual connection to the outside world. Paramedics, even doctors, are willing to stay back in their own hometown, because today on a giant screen, they interact with specialists, super specialists. They are continuing medical education programs. They are no longer isolated, be it academically, be it socially, and so on and so forth, through virtual networking opportunities. I mentioned earlier that legal, regulatory, and security issues need to be compliant with. It is sad that India is slowly coming up to where the United States is. The All India Institute of Medical Science, the showpiece of healthcare for 1/6 of the entire world, was hacked into a few months ago, and almost 48 hours, there was a major problem with several million records being hacked into. So hacking of health records has also become an isolated reality. Urban teleconsultants need to be sensitized for a community interaction. I am an exception. I have visited the towns and villages across the length and breadth of India, so I have a very good idea of what the real world is. Most of the urban elite consultants do not do so, and hence every now and then, we try to hold orientation programs for them, tell them this is what the real world is. We very strongly believe that motivation is the key mark. It is not your paycheck alone that matters. And I have a wonderful team who ensures that every time there is an opportunity, we publicly place on record our immense gratitude to our hundreds of paramedics, nurses, and doctors who, unwept, unhonored, and unsung, are behind the scenes and making what is a theoretical discussion today into reality. Nurses Day. This is the gentleman you see here, Mr. Premanand, my chief business officer. He is the one to whom I have literally handed over everything. He does a great job. And here you can see how nurses from most of our telemedicine centers are on a virtual interaction where we publicly recognize the work that they do. The business of telehealth. Lectures such as this, and I'm grateful to Professor Imike, lectures such as this, articles, etc., enables us to put our thoughts together and understand what we are doing. I personally love talking for a very selfish reason. When I put my thoughts together, I realize that I've overlooked this, that, and this helps me become better. We have published a few papers, the rigors of publication, particularly in management journals, You can see here, this is from the University of Pittsburgh and University of Harvard. I think it's a good recognition for us. Shobha Ramanathan is from the Chain School of Public Health, Harvard University. Professor Camillus is from the University of Pittsburgh and so on. So in Tuvalu, we run a project with the assistance of the University of Pittsburgh. We have published a paper. Of course, many of this are far beyond me. They are only for intelligent, educated people like you. I don't even know what is Kurzweil singularity. I just gave all the information, etc., and help in this. So this is what we believe. So, ladies and gentlemen, I could go on and on, but I would rather spend some minutes in an interaction with you. This is a slide which I made just about a year and a half ago, and I believe this slide says it all. Professor Aimike spoke about innovation. Sir, here is an example of 10 below poverty line farm laborers earning less than $2 per day. All of them had some health problems. They live in very remote areas. And what did they do? They knew that we had a telemedicine center 15 kilometers from there they were. How do they travel 15 kilometers? They chartered a round trip, a bullock cart. Imagine India is going to launch its third mission, Chandrayaan-3. In another few days, we are going to land on the moon. We have already sent planning to send in Martial orbit, indigenous. A country like that, this is also the other extreme of the country, a round trip they chartered for less than $2.50. So each one of them had to pay 25 cents for a round trip. And what did they give? They remotely consulted family physicians and dermatologists of Apollo Hospital, Chennai, free of cost, with free basic laboratory tests and medicines. Delighted that a globally renowned chain of hospitals is using technology to reach the remotest centers. Thank you, Business of Health and the University of Pittsburgh, for funding this project for the last 2.5 years. What the urban elite would have had to wait for 45 minutes to see a senior dermatologist and probably pay $25, these people got the same dermatologist in Madras city, saw them, and this is how they came. If Moses were to come back to the earth in 2023, I strongly believe that every one of the 10 commandments would have the prefix, thou shalt digitally transform. You can ignore reality, but you cannot ignore the consequences of ignoring reality. The future is always ahead of schedule. In 1998, when I first heard the word telemedicine and decided to get into it, telehealth was a dirty word. Today, thanks to COVID-19, telehealth is being incorporated in the armamentarium of healthcare delivery, not only by the private doctor, not only by small nursing homes, clinics, hospitals, but most important, by the government of India. No less a person than the Prime Minister of India mentions telehealth at least once a month in one of his national or international talks. Without political will, it is very difficult. We will not achieve that critical mass essential for a successful takeoff. Now, with the political will, both at the federal level and at the state level, I believe that in my lifetime, the day is not far off when every single hospital, every single of the 710 medical schools in India will have a department of telemedicine. And I dream of the day when I may not be there, but I dream of the day when 10, 15 years from now, telemedicine will not, should not, need not exist as a separate department. There is no stethoscope society of India. No one promotes the stethoscope. Of course, today the Lancet has said the obituary of the stethoscope. Today we are talking of 3D digital echocardiograms which can be put in your pocket. What I'm trying to get at is this telemedicine is only a tool. There should not be a telemedicine society of India. The American Telemedicine Association ideally should not exist 10, 15 years from now, because telemedicine would have become an integral part of every single healthcare provider, be it a super specialist or be it a preventive public health specialist. Thank you, Professor Aimike, and all of you once again for the patient hearing. If there are any questions, I'll be happy to take them.
Doctor, that was fantastic as always. Thank you. It's a once in a lifetime opportunity. Unmute yourself. Jonathan, I see your hand up.
Dr.K.Ganapathy, first of all, congratulations. You're truly amazing and leading the way. And I'm sure that the goal that you have, you will see it in your lifetime because you have put in the work. I have a small non-profit. I opened up a school in a village in Colombia, in the coast. And the only way to get there is by boat, that it takes 2 hours, or by plane, right? Which, you know, it means a high cost. If I'm trying to open up a telehealth clinic for my school, which has 250 kids, what specific technological infrastructure would I need, considering the limited transportation, and what kind of support or assistance would be required from the government to successfully implement and sustain the telehealth center?
I wish I could answer your question. I honestly am not familiar with the infrastructure at present available. The first thing I would do is a detailed, what we call a need assessment study. And if I have a formal communication from you, we could help you design that need assessment study. You need to fill that questionnaire, tell us what is the connectivity. Connectivity is the most important thing. The single most important thing is connectivity, whether we use the internet, whether we use VSAT, whether we use ISD and telephone lines, whether we use a mobile network, etc. And of course, the availability of the specialists at Rio or wherever it is. Sorry, you said Colombia. The city-based Colombian doctors, etc. And you can, it will be difficult for me to answer your question here, but I would be happy to help you. You can send me a note and I will try to get some information and send it to you.
Thank you so much. I will.
Suma?
Thank you, Professor. Sir, it was just such a pleasure to hear you. I'm actually from India, so I feel very happy to hear a lot of what you said. One of the questions I have is the healthcare situation in terms of how it's being handled in the United States is actually a very big challenge. India, I think, is doing fabulous in terms of how it's handling it from a very nimble, entrepreneurial, innovative way, and some of which you have named. What do you think, US as a country can do to overcome some of the challenges that it's facing today? What do you think are the issues?
Well, as an outsider, I really don't know whether I'm competent to answer that question. My elder brother has been living in the United States for 56 years. My son lives in the US for the last 20 years. I have a lot of relatives there. So from an indirect, and of course, most of my classmates, unlike me, who I decided that I'm going to be in India, most of my classmates are in the United States. So based on the secondary and tertiary data, I believe one of the major factors responsible for the present US health is the litigation attitude. Malpractice is very, very high. Some of my classmates have stopped their medical practice because their malpractice insurance comes to almost 10% of their annual income. So I think that the word trust, faith, India, in spite of all its development, when a patient comes to me and I say, look, you have a brain tumor, you need to get operated tomorrow, he'll say, yes, sir, that's it. The trust is not there, the implicit faith and trust. I'm not for a moment saying the patient should not question the doctor. Yes, of course it should do. So one is the malpractice. That should definitely reduce. Two is, I think, the cost. I mean, insurance. I know neurosurgeons spend more time in coding in order to get reimbursement from insurance companies. They describe the operative procedure in great detail because insurance reimburses according to every step of a neurosurgical procedure. I mean, enormous amount of time is spent on paperwork, even though it is digital paperwork. So I think these two are major things. Number three, at the end of the day, there has to be an upheaval. Quit India. India attained independence because Mahatma Gandhi said, quit India. I think unless there, at the end of the day, it cannot be imposed from above. If 10% of the American population say, we can't take it anymore, this is it. I mean, I know people, including my own brother, who, because Medicare and Medicaid, senior citizens are not exactly popular among most doctors because the reimbursement they get is less than for a non-senior citizen. He has to wait 12 weeks to get an appointment with a specialist, another 4 months for an endoscopy, and so on and so forth. So I think there should be a mass movement from the beneficiaries pointing out in great detail, look, this is what is happening, this is what is happening, this is what is happening. We cannot take this anymore.
Wisdom on every level, Doctor. Thank you so much. I'm forever in your debt, and I feel so lucky that we've been able to allow our students to at least meet you virtually. So hopefully someday soon we'll get you back to the US. I know you come here, but we'll get you to Columbia. So we'll wish you a very pleasant day, and thank you again for joining us.
Thank you, everybody. Thank you. Bye. I'll sign off now. Thank you.
Good night, sir. Thank you.
Bye.
Class dismissed. I hope you enjoyed it. I hyped it, but I think he was even better than he is normally. So I hope you enjoyed it, and I'll see most of you hopefully in class next Wednesday. Have a good night, everybody.